The Hopeful Heart trial we conducted to look at the impact of treating depression and heart failure together versus treating heart failure alone or doctor's usual care. It's really a follow-up on a study that we published in JAMA in 2009, looking at the impact of treating patients after cardiac bypass surgery for depression. And in that study, we had a team of medical nurses who telephoned patients at regular intervals and recommended social engagement, exercise, getting sleep, quitting smoking, etc. And we found that patients had significant improvements and recovered faster than if they didn't get that treatment. They had less pain. They also saved about, the health insurance companies saved about $2,000 in the first year after bypass by treating the depression. But I always wondered in that study, the control group was usual care, and I always wondered if we were really making a difference or if it was just the impact of having nurses telephone the patients and be concerned about their health that was treating the depression. So in our latest work that we just presented at the American College of Cardiology in New Orleans, we enrolled 756 patients with heart failure at 8 Pittsburgh area hospitals. We screened patients for depression using something called the PHQ-2, which are down, depressed, or hopeless, or tired or little energy on most days in the past 2 weeks. But we didn't want to call people depressed in the hospital because the symptoms of depression clearly overlap with simply being in the hospital for heart failure exacerbation or something. So we called people up 2 weeks later to administer the PHQ-9, and if patients scored 10 or above, which is considered a clinically significant elevation in mood symptoms, they were then randomized to one of 3 interventions. Also want to add that the PHQ-2 and the PHQ-9 were endorsed in a position paper by the American College of Cardiology and the American Heart Association back in 2008, where the colleges recommended routine screening of cardiac patients for depression. But to date, 11 years after these guidelines have come out, doctors are not, and health systems are not routinely screening for depression. Sure. So in the study, we enrolled 756 total patients, or 101% of our recruitment goal. Of the 756 patients, 629 were depressed both in the hospital and 2 weeks later, and 127 were served as non-depressed control patients. That is, they had heart failure, they screened negative on the PHQ-2 in the hospital, and they screened below a 5 on the PHQ-9 2 weeks later. We included a non-depressed comparison group because we knew some heart failure patients would die, become readmitted, and have other kind of medical issues over the 12-month course of follow-up. So we wanted to have a true comparison group. Now, we focused our interventions, I mentioned on the 629 we randomized, and we randomized those patients to one of 3 arms. One is their doctor's usual care. 2 is heart failure care management, which is currently a standard in the United States at a lot of large institutions like UPMC, like Kaiser, Intermountain, and others. And then the 3rd arm was not only providing expert heart failure care management, but also depression care. So we trained up a team of nurses to provide both depression care and evidence-based heart failure that they would deliver over the phone under the guidance of a study cardiologist and a study psychiatrist, and we'd have weekly case review sessions, and our nurses would take those recommendations back to the patient's GP and to their cardiologist with treatment recommendations. Well, there are a couple of key findings, and one is that depression was fairly common in heart failure patients. Approximately 46% of the patients we screened in the hospital who consented to enroll in our study screened positive for depression. And of that 46%, 36%, or over a third, scored with clinically significant mood symptoms 2 weeks after hospital discharge, number one. Number 2 significant finding, at baseline, we found that depressed and the non-depressed patients were similar. They had a similar ejection fraction, the mean was 28%. They had similar rates of diabetes, having a heart attack, bypass surgery, hypertension, etc. Similar rates of use of beta blockers and ACE inhibitors, other evidence-based care. But the patients who were depressed rated their health as significantly worse on the New York Heart Association classification and the Kansas City Cardiomyopathy Questionnaire and the SF-12, even though they were essentially the same severity and disease burden as in non-depressed patients. The third important finding is that our blended collaborative care intervention significantly improved mental health related quality of life at 12-month follow-up compared to doctors' usual care, and also significantly improved mood symptoms compared to the depressed patients randomized to the usual care, as well as the depressed patients who were randomized to just heart failure care management alone. So we know our treatment worked, and it was more than just the non-specific effects of having nurses telephone patients to see how they were doing and adjust their heart failure care. But we did not see significant differences at this point in rates of hospital readmission. So at 12-month follow-up, roughly 90% of the heart failure patients were readmitted at least once, compared to about 75% of the non-depressed. Although we need to look at this further, so readmission for cardiovascular versus other causes, and also the mean or median number of readmissions. So some of our patients were rehospitalized 10 or 20 times over the 12-month follow-up, but the analyses that we've done so far only look at the time to first hospitalization. The fourth point I'd like to make is that our intervention did not make a significant difference on all-cause mortality at 12-month follow-up. At that time point, approximately 14.5% of the depressed patients died versus 10.5% of the non-depressed. So it's about a 40% increased risk, but we're still continuing to follow those patients. And as we did with our bypass study, we later presented data to show that the depressed post-CABG patients had significantly increased mortality. And we think as we follow these patients, we may see the same. And finally, the last thing I want to say is that we need better treatments for depression. So our treatments were evidence-based. We encouraged social engagement, stopping alcohol, getting sleep, eating healthy, quitting smoking. If patients were interested in antidepressant medications, we made suggestions. But even with the treatment at 12 months, the depressed patients did not score close to on the KCCQ-12 or the SF-12 as a non-depressed comparison patients. So we need to do better. We need better treatments, and we're working on that now with newer interventions for exercise and something called psychonutrition in our next series of studies that will come from the Hopeful Heart trial. For your listeners, for your readers, if you'd like to find more information about our study, visit our website at www.hopefulheart.pitt.edu. Our study was entirely funded by the NIH in the United States. There's no drug company support. There's no industry support. But if you come to our website, you'll see that you can download for free the PHQ measures and our paper describing our study methods. Thank you.